Hey, everybody. Welcome to another episode of the Serdentity podcast. I am your host, Elizabeth Dewar Anthony, and I am absolutely thrilled to have my good friend, Dr. Dave McCarty here. Um,
Hello.
he is the creator of Empowered Sleep Apnea.
There's the
Look at that.
product placement. I'm drinking my tea.
And he's a doctor. So I want to just have a chat with him today. Dave, how are you?
I'm doing great. Thank you for having me on the show. It's a pleasure to be here.
Well, the first thing I want to talk about is when we met, which was last October
Hmm.
at the Bob Barkley Study Club. And you were so kind. I was
Oh,
really nervous.
well, we had I'm embarrassed to say I don't remember the name of the musician that Dr. Henney had hired to come play the bash afterwards, but he was a really talented a guitar player and sort of roots music,
Yeah,
like
yeah. Oh, he
Americana
was
music,
good.
and was just playing some great tunes. And he started playing Angel from Montgomery, and you were standing on the sidelines and you were singing beautiful harmony, but you just wouldn't go up. So all I did was tell you to go up and sing into the microphone so we could all hear it.
That still is goes down as one of the greatest nights of my life. I was there
Wow.
with a whole bunch of people who I have a lot of respect for, and that I was able to get up there and sing and do, and show that side of myself. You know, when I'm singing, that's like the real me. And
Mhm.
so you're a musician, you know about this. When we're in it, right? When you're in the zone, it's so amazing because you kind of forget yourself and you're in the music, and then if things are going well, the audience is right there with you. And
Yeah. Yeah.
that feeling,
It's the closest I can come as sort of who I am to being one with the universe,
oh my
being
gosh,
one
yes,
with the
absolutely.
creator is that you can resonate in those frequencies and you can find that place where you really do bond in a weird way.
Yeah, it's not, it's I've had actually some pretty profound s- spiritual experiences while singing um in church.
Believe
And
it.
where I've had like a profound spiritual, like almost like a uplifting, like a dissociative sort of state where, but the people who were watching me saw it too, and they were part of it. And that is it's incomparable.
Well, it's a different way of obtaining something that human beings can rarely get to, which is this almost a divine empathy, where
Yes.
you can feel what other people and you can have this sense of connectedness. And you just don't get there with everyday conversation,
Not usually.
but music can get you there, spirituality can get you there, but it's a special place to go to, and I'm really grateful to have music in my life for that reason, for sure. Are you familiar with the Pulmonauts Music Project?
No, but I think I'm pretty sure I costed you about it when we were together. And so I hope that next time the Pulmonauts are doing something that I can get in on
Well,
it.
yeah, well, we are playing the Collaboration Cures conference
Oh,
in
in
Reno
September.
in September.
Oh,
We're going to be taking the stage and doing a pretty long set that we're all still in the process of learning. But the reason I'm bringing it up though is that this is this is a collaborative art project in motion.
mhm,
We all talk about how it's important to collaborate. Well, we're all airway adjacent professionals, but from
mhm,
different walks of life. And we all came into this with sort of our own iteration of the way things are. And it's through working together in this band that we're actually learning one another's vocabulary and strengths as professionals. And I
mhm,
think that's an amazing thing to come out of what could be just a garage band.
mhm.
We're playing rock and roll, but to do so requires kind of lowering your ego a little bit and getting together and grooving as a group. And like you said, there's a relationship that happens there that's very, very special. It
Mhm.
doesn't happen in everyday life.
And egos. Oh my gosh, I've been in enough bands and made music with enough different bunch of people to know that, you know, if somebody's ego is involved,
Well,
it's
it's a fragile
hard
it's
for
a
everybody
fragile
else.
place to be. And so, the group cohesion sort of requires that it's safe for everyone to create. It's a safe space. And the problem with the ego needs is that they sort of trounce on other people's safety sometimes. So it's a delicate balance
Hmm.
working with a group, as you know, and that's part of the magic is when it happens, it's real.
Yes, yes, it's real. So that was the first thing I wanted. But when I very first met you, so you were sitting in this chair in Dr. Henny's library, and I just kind of like pounced on you, and you were so kind. You jumped right up, and we introduced ourselves to each other, and we just started talking, and it was your kindness and your humility. You weren't like, oh, I'm a doctor, blah blah blah. It was just like it was two people just relating. And so I was there, all by myself. My husband was with me, but I didn't come with a team. And I'm just a hygienist, but I do have a little bit of that imposter syndrome going on. And to be in that group of people, I was a little, I felt like I was a nerd
Mhm.
that somehow got in with the jocks for a party.
Well,
And
isn't it remarkable that that it requires that sort of an introduction, that the ego needs of the profession seem to be front and center for the way the professions relate to one another. So I find these discussions, the starting point is equally remarkable, the fact that you had to start there.
mhm. So when you were on with some of these other airway rock stars on that meeting, when we were all talking about collaboration, but your points, especially when you were talking about silos and talking about, was it Ignac Semmelweis?
That's the one. That's the one. Ignaz Semmelweis. Yes, the
And
father of modern hand washing.
yeah, and dude, he got like run out of his,
Yeah. Yeah,
nobody believed him.
my final analysis of that situation, for those who haven't heard the story, the father of modern hand washing, this happened back in the 1830s, before germ theory, and Ignaz Semmelweis deduced that it was something to do with the cadavers that was infecting mothers with puerperal fever. And it was, of course, they were doing the
Hmm.
autopsies with bare hands and then going straight to the birthing
Right,
wards and
right.
doing exams. So he was right, but his rollout was problematic, shall we say. And so, what he did was basically announced his real world data. And everyone sort of said, well, puerperal fever is seasonal and it comes and goes, or whatever they were saying back then.
Hmm.
And so they wrote off the fact that he dropped his mortality rate to almost zero. And he never really followed up on that. He wrote a book where he kind of attacked his enemies and the people. And
Hmm.
mostly what he did is he threw he threw stones at people, so to speak. He denigrated their intelligence, their morality, because they wouldn't listen to him. And he eventually got run out of town on a rail, as they say. And it's terrible. In 1865, he was admitted to a lunatic asylum, and he died
Hmm.
14 days later from injuries that were, he was posthumously exhumed, and they found his remains. And he had thoracic trauma that they thought could only have come from a boot stomp. And if that's what we, think about that for a moment, this is what we as a society did to him with a new idea that was paradigm shifting. So, I feel like we all can learn from that experience somehow, you know?
Hmm.
And I think what Ignaz Semmelweis did right was he was receptive to new information and he recognized how important it was. What he did wrong was he forgot how new information is terrifying to the people who are living through the transition, and how we must be humane with sort of rolling this out and helping people make this transitional switch to this new idea.
Wow.
I think this is what we're up against these days with the whole expansive orthodontia narrative, is that there's a lot of folks who've built their career doing, four bicuspid extractions and
Hmm.
retractive orthodontia, and it's very difficult to square off with maybe this has caused some harm, you
Hmm.
know, and so
Well, yeah,
there's a very
iatrogenic harm.
Mhm.
Um, you know, so first of all, I understand exactly where was he a physician, Dr. Semmelweis?
He was on the medical side. You know, this
Um,
was before really modern medicine as we know it,
right.
but you know,
Well, back then, the barber and the dentist and the bartender were all the same guy. And if you needed a little off the sides and you had a toothache, they got you drunk and then they brought you over in the corner and there was this chair. But anyhow, this idea that we're talking about humility and ego, and I do have a tendency to want to get on a high horse and think and dismiss people people that don't agree with me. And
mhm,
well, you're wrong. If you don't agree with me, you're wrong. But so trying to bring that in line with this idea that we all have to combine our knowledge base and collaborate if we really want to help people. And so you're a physician. And
correct.
how did you come to sleep apnea?
Well, I came to sleep apnea through the sleep medicine pathway, and this is a rather late bloomer. And so for folks who are like wondering where this came in and what did they miss, that's with good reason. This is a new specialty in the field of medicine. Um, it started in the 60s when polysomnograms started to become a thing and people started doing sleep studies. From there, it evolved into a certification process to just be able to read sleep studies. And from there, it evolved into an outright multidisciplinary specialty within medicine itself. And that's what's so confusing about it. So to get into a sleep medicine residency or fellowship program, you can come from internal medicine, pediatrics, family practice, anesthesiology. What am I missing?
Mm-hmm.
Uh, otolaryngology.
Mm-hmm.
So, you know, we're talking about disparate fields of medicine that are all coming together. I mean, psychiatry and neurology are the last.
Absolutely.
So, you know, many different specialties, but they're all going to be doing the same job purportedly. So obviously each one comes in with their own lens on how
Mm-hmm.
the job of doctoring should be done. And it's led to some pretty interesting divergence of how practice patterns happen depending on which location you have to be in and things like that. Similar phenomenon has happened in dentistry. You know, there are people who embrace the expansive orthodontia narrative, and they've gone on to all kinds of continuing ed, and there are those who don't, and those people can no longer speak to one another anymore. And that's very difficult because this is sleep apnea is a problem that affects a billion persons, a billion adults worldwide. But you asked me how I got into sleep. So I started my pathway as a primary care doctor. That's the
Mm-hmm.
lens I brought into my situation. So I'm an internal medicine trained primary care doc, which meant at the time that I was taking care of my patients, my adult patients, inside and outside of the hospital for medical problems. So it was usually complex medical disease. So I was used to sort of dealing with the complexity and dealing with, trying to pare down the med list, trying to get things as simple as possible for this human being under my care. And it was with that lens that I started to send a lot of sleep studies because I was trying to figure out why all these people had high blood pressure that was so difficult to manage. So
Mm-hmm.
I started out responsible for their blood pressure, and
Mm-hmm.
I began sending sleep studies. And it was in this sort of journey that I realized that, the person who was doing the sleep studies and prescribing the CPAP machines didn't have a great relationship with many of my patients. So he would kind of use the very, you have to do this or it's going to give you a stroke kind of thing in a very sort of enthusiastic technique, but it didn't gel with everyone. And so a lot of people would come back and say, I'm not seeing that guy anymore.
Mm-hmm.
And then I'd be left like, what am I going to do now? And so
Mm-hmm.
I bought a textbook. I bought Principles and Practice of Sleep Medicine, the third edition back then. And I read it cover to cover. And I that was my rabbit hole, honestly. I realized how deep this hole went and how little I knew. And it was then that I called up a man named Andy Chesson, and he was a past president of the American Academy of Sleep Medicine, but he also happened to have a small sleep medicine program at the med school there in Shreveport, at LSU Shreveport. And so I called him up and asked him if he would train me. And he said, well, I can't pay you, but if you come in on these days, when you're ready, I'll, say that you can sit for the exam. And I said, okay. And so for 2 years, I went as an unpaid fellow, and I followed Andy Chesson around, and I learned to read sleep studies first on the paper ones and then on the
Mm-hmm.
computerized system. And I learned about all these new diagnoses that we hadn't learned about in medical school or residency. And I was hooked. I was hooked. And at that point, I just wanted to continue teaching and learning. So I stayed on as faculty there.
Mm-hmm.
And when Andy retired, I took over as the director of the program at the fellowship, which I helped him get accredited. And it was with that background that I decided I wanted to move to Colorado and enter into the private sector, because I felt like the academic setting was a little too limiting. We couldn't have enough lateral reach for what we
Mm-hmm.
could offer. And so I wanted to come to a little more comprehensive type of a situation. So that's how I ended up in Boulder, Colorado.
Well, Colorado's awesome, and
Uh,
it's no wonder you ended up there. I lived in Colorado Springs for 7 years,
yeah,
over 20 years ago, and I still look at Pikes Peak every single day on
nice.
on the webcam. So
Yeah.
I am dying to get back out there as soon as I can. So some of the things that you just mentioned got me thinking about when you were talking about the patients not liking the approach of the doctor. And I'm
You
not
know,
going back to that guy. I can't
mhm,
tell you in the dental setting how often I hear that. And it
mhm.
doesn't matter if this doctor is the greatest trained, most technically skilled practitioner on the planet. If they can't engage their patients, the patients aren't going to come back.
It's
And
the hard psychology of doctoring that is not very well taught in many locations, which is that this is a complex disorder, and the way individual patients experience it is variable in person to person. And not everyone's ready for a treatment or even understands what you're saying well enough to absorb it.
mm-hmm,
And so it can be a terrifying experience on the other end. And none of that is really, it's not part of the subject matter in medical school, honestly, that
yeah,
the empathic connection.
yeah.
Somebody who's writing about this recently, I'm reading a book right now by Alan Alda, and it's called If I Understood You, Would I Have This Look on My Face? And he has made a sort of a career, a second career for himself as a communicator and someone who teaches other people how to communicate with each other. And he's founded a center up at his alma mater, I believe, where they study how to create empathic connections with people. And a lot of what he's used as a vehicle for this, interestingly, is improv comedy.
Mm-hmm,
And as a performer, I think this goes back to the first part of our conversation about music, is it's
mm-hmm,
the improv comedy that forces you into a lens of, I'm going to watch that person and try to figure out what they're thinking, you
mm-hmm.
know, by observing body language and things. So there's ways you can train up that
Yeah,
skill. And I was thinking that music does the same thing.
yes. And so that empathic, so Serdentity is a combination of serene and dentistry. And it's what I'm trying to get across to my fellow dental professionals is this empathic connection. And because dental fear and dental trauma is still happening.
Mhm.
And there's dentalfear.org, and you can go on there and
I
read.
think it's good you have a name for it and that you have language for it, because I think that same phenomenon occurs when people have CPAPs indiscriminately thrown at them with these outrageously high pressure ranges. It's traumatizing, and
Mm-hmm.
they do not want to go back.
That's interesting. So how I go about it is in my talk, Roots of Dental Trauma, I first talk about trauma informed care, the neurobiology of trauma, what's going on in the brains of these people that are annoying us and are in the dental chair. And then but it's the airway. People can't breathe, and that's why they are panicking in the dental chair. And a lot of times that behavior doesn't present as fearful. It can present as like mean,
Yeah.
rude. And what I see is in these different dental groups and dental hygiene groups, uh, practitioners, I'm going to rant for a minute and, complain, about this rude patient and blah, blah, blah. And there's a lot of judgment, and there's a lot of this, what I call the medical religious, medical thing where you're blaming the patient. It's their fault. Oh my God, do you not even take a shower before you go to the doctor? Like these people, dental professionals not understanding that somebody's oral hygiene is not the top priority in their life. And they're actually, it's affected by so many other things besides flossing and brushing.
Mm.
And
Well, I think this speaks to a larger problem, which is there's an othering that's happening in that situation.
mhm,
Right? And I think that this speaks to the larger problem of what I call fragmented healthcare delivery syndrome, which is that every place you go is, it's its own little sort of ecosystem, and somehow, unless you fit in right in step with the way they do things and the way they understand the world, if you're left out of that, it can feel like you're getting run over somehow, and
wow.
and I think that it has to do with the fact that the common understanding of the complexity of what we're up against isn't something that most people grasp, that this larger understanding that when you go to the dentist, it's partially about the airway. Some dentists they can't hear that. Again, maybe it's because of the silo of thought, the division of the expansive versus retractive, which line of that you fall on. If you happen to be blocking out all new information because it's just too disturbing, you can't hear that anymore,
Hmm.
And so somehow, to me, this requires a unification of language on how we talk about this problem.
That is a great idea. When do we start? When do we get started?
Well, that's what the Empowered Sleep Apnea Project is about. So, the Empowered Sleep Apnea Project, and if anybody listening and watching wants to sort of see what this is about, it's empoweredsleepapnea.com. And
Oh, I love it.
it's a multi platform educational project. And it's really designed to give people the language, whether you're a provider or a patient, that you can talk about this terribly complex problem and deconstruct its complexity responsibly in a predictable way that everybody can share. So the whole project revolves around two 5-point mnemonics. One
Mhm,
is the 5-finger approach
mhm.
to nondescript sleep wake complaints. That's based on a paper that I wrote back in 2010 when I was still at LSU. If you want to Google that, it's 5-finger approach sleep. It's the first thing that comes up. It's called Beyond Occam's Razor.
Wow.
And so that's a way that doctors, providers of any stripe, and patients can work together to collaboratively deconstruct a set of non-specific sleep-wake complaints. Doc, I don't feel good. I sleep poorly. Doesn't equal sleep apnea,
Right.
It equals a big question mark, and we have to
Mhm,
deconstruct that. So that's what the 5-finger approach is about. The other 5-point mnemonic that the Empowered Sleep Apnea approach is based on is called the 5 reasons to treat. And this is a deconstruction of why we would want to consider a treatment strategy for sleep apnea. And it involves a lot of jargon, especially because the 5 reasons to treat are risk, snoring, sleep, wake, and comorbidities. Okay. And if you don't have any reasons to treat, then arguably there's no reason to do anything. But most everybody with the label sleep apnea can deconstruct their problem with using that structure. And risk, meaning, is this problem going to kill you younger than if you didn't have it?
mhm.
Because we know sleep apnea makes people die younger, and
Yes.
the signal is strongest for cardiovascular demise,
Mm,
but all-cause mortality, including accident-related death, and cancer mortality, are elevated in
mhm.
people with sleep apnea. So it's a problem. but it's not the same for everybody. And just because you have that label doesn't mean you're going to have a stroke if you don't use your CPAP. So
Mm-hmm.
it's a continuum, and deconstructing what that risk looks like for a given person means that there's got to be the ability to really open up and unpack the severity metrics that everybody talks about as if they all mean the same thing. But
Mm-hmm.
the notorious AHI, which has about 6 different meanings depending on who you talk to.
Yeah.
So that, that metric isn't enough, and it must be unpacked for every individual patient, and the degree to which this represents a survival risk must be unpacked for every patient. Beyond that, snoring, not everybody with sleep apnea snores, and sometimes people snore and they don't know it.
Mm-hmm.
Snoring is trauma. So snoring is related to upper airway inflammation and possibly even atherosclerotic plaque deposition in the neck because of the rattling trauma there.
Mm-hmm.
The sleep experience, if that's problematic, that's reason number 3. The sleep experience, if that's problematic, like I can't sleep, I wake up a lot, I sleep
Mm-hmm.
poorly, that's a reason to treat. The wake experience, if that's problematic, I'm tired, I have
Yeah.
brain fog, I can't, I can't prioritize things, I'm upsettable, I have anxiety. All those are wake impairment symptoms that could be related to sleep. So if those are issues, then that's a reason to treat. And then finally, comorbidities. That's a
Mm-hmm.
fancy mouthful that means other health problems that sleep apnea probably is making worse,
Or
right? So if
creating.
or maybe it's the biggest factor, right? So
Mm-hmm.
migraine headaches, TMD, high blood sugars, high blood pressure. The list goes on and on and on in terms of what problems could sleep apnea make worse. And so if you've got some of those, then that constitutes a reason that we might want to do something about the sleep apnea that's definitive. But you can imagine that every single person that has this discussion, I have sleep apnea, what do I do? Wait. It's not what do you do? It's why are we going to do it? Let's talk
Mm-hmm.
about the 5 reasons to treat. And then
Mm-hmm.
let's talk about these things that are out there. And are they capable of solving those reasons, like getting you closer to goal with those reasons to treat?
Mm-hmm.
That's the question. And often it comes up that there are several things that one can try, you know?
Mm-hmm.
And lots of ways across the river is the way I put it in the island of sleep apnea literature. But the river of decision that takes you from untreated territory to treated territory,
Mm-hmm.
should you go there? And there's many ways across that river. And once everyone is kind of comfortable with these conversations, and patients come to their provider saying, hey, I know there's 5 reasons to treat, here are mine, what's the
Mm-hmm.
most likely thing to get my AHI down? It starts to become a more meaningful discussion.
Wow. So I'm a classic or extraction retraction orthodontics. I have sleep apnea. I have high blood pressure. And I have a CPAP that I started wearing again. I was wearing it and then I stopped. And then, but what I noticed was that I was having these nightmares where I was yelling for help in my sleep. And I'm like, duh, you can't breathe. That's
Were
why.
you having any dreams of like drowning or smothering or anything like that? I
Um,
would hear a lot about that.
not no, it was really they were very interesting because it was darkness with a sense of something really bad, like
Okay.
just over
So
here.
a sense of impending doom
Yes.
almost. Yeah.
So I finally, like, put the puzzle pieces together. And so I started wearing the CPAP again. And I didn't used to think that it really affected my sleep, but it does. And
Yeah.
but it's still not
Sometimes it's only
ri-
part of the puzzle too, right? Because it doesn't take a lot of introspection, but just because you sleep poorly doesn't mean that fixing sleep apnea is going to make you sleep great, because there's about
Mhm,
1 million things that can make you sleep poorly too, besides
mhm.
sleep apnea. This is why the complexity unpacking is so important, that it's done responsibly and in a way that kind of uh, uh, it respects the patient's journey,
Yeah,
you know?
respecting the patient's journey. But also, it was Thomas Edison, okay, and that darn electric light bulb. Everything was fine until then.
True
But now
that.
there's all this artificial light. We don't know if we're asleep or awake. Our whole circadian rhythm is off, but I
It's all
digress.
part of it. It's all part of it. So, well, good stuff.
Honoring the patient's journey, that's and again, that goes right back to the core of trauma informed care and Serdentity, meeting patients where they are at and not shaming them. Dentistry is getting better, but I know as a hygienist for 35 years, there's still way too much focus on clean versus dirty. And that is shaming. When patients come in, I'm going to do a cleaning. That's in right there. You're implying that this person is dirty, and
Hmm.
that's shame inducing.
Isn't
And
that interesting? I once had a patient who was very angry with her prior sleep doctor because what was dispensed at the prior appointment was something called sleep hygiene
yes, that's a
instructions.
big buzz phrase.
Yeah, and she said, and he told me I was dirty. Because that was the impression she was left with. Because when you're told about sleep hygiene, you feel
Right.
like you're being told that you're unhygienic. So I get it. Language is important, right? It can
That
change the way it's perceived.
and that speaks to so who knows what that doctor actually said to her. What she heard the word hygiene, and she went,
Um,
you know, in her
well, she was
filter.
told she was told she had poor sleep hygiene, and so she was given these sleep hygiene instructions,
Right.
and that's just that's actually how it's taught to us. That it's a diagnosis code that you can find somewhere, poor sleep
Right.
hygiene, and so it becomes so jargonistic that you forget what it feels like to be a human being who's a little afraid and is intimidated by the white doctor code. You know what I
Mm-hmm.
mean?
Oh,
And
yes.
so
Well,
all of that is absolutely true, and the empathic connection that you're talking about is really just having the wherewithal to stop and watch
yeah.
and observe the nonverbal language, and see if this person is experiencing this the way you intended.
Right. And they don't teach that. They they generally, it might be better now. It might be better now for these younger people coming out of dental.
It's the kind of thing that's usually taught culturally, and usually by someone that you observe in your clinical environment who does things in a way that feels right to you. That's the way it was in my training, is that I was able to interact with some providers who had this ability to connect. And that one of them actually told me a secret. He says, when I'm taking the respiratory rate, I'll be taking their pulse, and I won't tell them that I'm counting their breaths, but I'll sync up my breathing with theirs. That's an interesting choice, because that's a form of mirroring where you
Mm-hmm.
get in sync with another person.
Mm-hmm.
They teach that in improv comedy, actually, theater
Mm-hmm.
games. But so mirroring the patient's breathing behavior, you can tell within 3 breaths if that person is tachypnic. You know what I mean? And
Mm-hmm.
and I used to teach my students that there's only 2 things that cause tachypnea, and you want to know about both of them. It's anxiety and bad things. you know so if a person's breathing too fast, then they're either anxious about the situation, which you probably is a nonverbal cue that you need to be careful psychologically, or
Mm-hmm.
there's something bad going on, like they've had a pulmonary embolism or something. You know what I mean?
Wow.
So it's a vital sign that if you take it with empathy, you can get some new information. And one of my mentors in residency taught me that, and I've never forgotten it.
That's amazing. And when you think about it, so breath is the essence of life.
Mhm.
And if I'm syncing my breathing with yours, there's a there's more of a connection than just we're breathing at the same rate. It starts to become, energetically, we start to become connected.
Well,
And
it's almost unavoidable when you're doing that. You're taking a moment and you're watching that person's face.
mm-hmm,
You know what I mean? And so
mm-hmm,
you can see the nonverbal cues that you can't see if you're busy tapping on your computer screen and asking questions with the expectation they're all going to be no.
mm-hmm.
Have you ever been assaulted with a review of systems where
Oh
it's
my
like
God.
any chest
Yes.
pain, shortness of breath, cough, fever, wheezing, and you're just like, no, and because that's what they need you to say, because they have to move on to the next step,
Mm-hmm.
and everybody knows it. And that is part of the way medicine has evolved into this machine that provides care, quote unquote, but it doesn't feel very humane to the people that are having to experience it,
Yeah.
So one of the main thrusts of this project, of your project and mine,
Mm-hmm.
actually, is that we're trying to reintroduce the humanity of the whole process, you know?
Yeah. And so I kind of I knew that there was fear. Once I started training as an orofacial myofunctional therapist, I understood it was the airway. But, I just kind of, Serdentity evolved as I evolved in terms of my own self and my own work on myself, in psychotherapy, in recovery from alcoholism, all different, a little piece of this, a little piece of that. And Serdentity comes from the Serenity Prayer. And serenity, I mean, to me, that's like the greatest state. It's nirvana, right? It's that state of, you're not necessarily super happy, but you're calm and you're not hyperventilating.
Mm-hmm.
And
Mm-hmm.
I found that when I have that state, that I create that state in myself, when I approach another human being, especially a dental patient who's been previously traumatized, I I can bring that down just from my presence.
Yes. Well, I suppose that the patient can sense that that their needs are observable and respected, and therefore the fear is assuaged as a result.
A little bit, people still, there's still reflexes and there's still, but the bottom line is, if I can create that sense of serenity. And I do that by being informed, right? Understanding the neurobiology of trauma, understanding about the airway, understanding about retained oral reflexes. And
Mm-hmm.
these are all things that create these behaviors that people are complaining about on Facebook. So if I take that information, how do education improves empathy, empathy increases serenity.
Mm-hmm. I think that's true. And it definitely paves the way to better collaborative communication.
Absolutely. And trying to keep my mind open, which I established early on in our conversation, that if you don't agree with me, you're wrong. But I'm trying.
Well, I think it's a measure of our own kind of fear in the process too. When you feel like stamping your feet and blowing steam out your ears, it's usually there's a fear in there somewhere that if you keep doing it this way, someone will be violated. Don't you
Mm-hmm.
understand what's at stake?
Mm-hmm.
So that it's motivated by a fear of a bad outcome.
Mm-hmm.
And that rapidly can turn into indignance, and I think that once that card is thrown, the problem is the person who we have friction with is no longer able to hear us anymore,
Yep.
and whatever truth we've experienced is just gone with the wind. And
Yep.
so the one of the major steps that I've been trying to complete, and mostly I'm there, is that despite the fact that the system is broken and that there are providers who are operating within this system in a way that harms people, and they don't even see it because the person leaves and never comes back, all of that may be true, but there is no one to blame. This
Mm-hmm.
is what happens to human beings when you put them in a system that doesn't work well together.
Mm-hmm.
So in fragmented healthcare delivery syndrome, it's not just the patients who suffer, it's the providers who suffer too.
Yes. This is, I recognized that, I was suffering too. So even though I treated people nicely all day long, on the inside, that indignance, that,
Mm-hmm.
that, like, I could feel it coming up. And by
Yep.
the end of the day, I was exhausted.
Well, it's a toxin on the system, that amount of anger and indignance. It's a dangerous thing to be carrying around in one's heart. And I guess the place that I'm trying to get to is just understanding that this is no one's fault. There is no one to blame. This
That's
is a
um,
systemic problem, and every single human is doing the best they can within the realm that they have with the constraints that they have, you know? And so for the ones, my siblings in arms, my clinicians in arms who are out there just really working it, time impoverished, 15 minutes per patient, doing the best they can. I feel you. It is a
mm-hmm,
hard role. It is a hard role. And it's very easy to sort of say, oh, that person's so angry. I just,
mm-hmm,
screw him. He's fired from the practice. He was
mm-hmm.
disruptive,
Yep.
you know?
Yeah. Just fire them.
And that's how things go down in that
Mm-hmm.
powder keg. It's not a conducive place to empathic bonding sometimes,
Right
but
there.
in my mind's eye, I've built this universe with the Empowered Sleep Apnea Project. In my mind's eye, if we can all meet together in that language, a lot of that is diffused because the patient is no longer disempowered. The patient has the same understanding of complexity as everybody else. And now we can all work together, including providers across silos, you know? So, the future is in collaboration, and collaboration requires communication. So that's where I'm going
Absolutely.
to be spending most of my time, is trying to spread this message.
Well, I'm right there with you, and collaboration is the solution. And I have great hope for the dental profession in the future because
Me too.
I think we're going to really, step up and take our place as, actual, healthcare providers, with understanding that. And Hippocrates and ancient Greek physicians had a much better idea of the mouth as a portal to the entire body than modern dental professionals do.
It's been perfunctorily sort of cut off as a
Yeah,
business enterprise, and so the thinking about it has been sort of limited.
yeah.
Especially since the advent of greater understanding of sleep apnea since 1980, and we've had treatment options for that. There's been an increasing disawareness in the standard dental community about these problems. We're just doing alignment and occlusion. That's
Mm-hmm.
all. And we're just doing cavities, and we're doing
Mm-hmm.
periodontal, but that has nothing to do with any of this other stuff.
Right.
So you know, of course, we see now that's a pretty thin veil to pierce. We see it's all connected.
It
It's
absolutely is.
scientifically that the narrative is clear, but there's a whole culture out there that's built their reputations and their lives based on this other understanding, and it's going to be we have to find a humane way to switch those gears.
Yes, and a humane way to do it. And thank you for the reminder, because sometimes I do. I get on a high horse, or I get impatient.
Mm,
And
I feel that.
so wow, we've been chatting for almost an hour, and
Yeah, it's been a pleasure, but
yes.
we both probably have other things to do.
Yes, we do. Yes. Yeah, well, I'm sure you do. But I just want to thank you for a wonderful conversation. And again, and for helping me, put a few more pieces of my own puzzle together.
Well, likewise, it always helps for me to talk to different folks, who have a different way of looking at the world, because this is a gigantic, gigantic beast, and I keep getting this idea that we have our little keyhole that we look through in our practice, and everybody sees things slightly differently. So thank you for sharing serendipity or serendentistry with me.
Serdentity.
Oh, I'm
Serdentity.
Serdentity. I got it wrong even the
It's
second time.
okay. Everyone's been misunderstood for 20 years.
Serdentity. No, I love the concept. Serenity plus dentistry. You know how much I love to make up words.
Right, right.
So that's a wonderful one.
Oh, well, thank you. So again, thanks a lot. And I look forward to seeing you again soon.
Yeah, likewise. We'll talk soon.
Okay, bye.
Bye.